Number 3, weight management. We understand that obesity is a known risk factor for complications in hernia surgery and many other kinds of surgery. Even modest weight loss can improve outcomes and reduce the chance of a hernia occurrence. For some patients, it's advisable to delay their elective surgery until weight loss goals are achieved. Surgeons will work closely with you and dedicated medical and surgical weight loss programs to help you achieve the goals that your surgeon feels is best to optimize your chance of success.
Number 4, blood sugar and diabetic control. Diabetes increases the risk of surgical complications, particularly when your blood glucose levels are poorly controlled. Work with your surgeon, primary care provider, and endocrinologist if you see one to ensure your blood glucose levels are at the desired range.
Comprehensive disease management. Your other chronic health conditions can increase the risk of complications after hernia surgery. Managing other conditions like congestive heart failure, coronary artery disease, asthma, chronic obstructive pulmonary disease, COPD, obstructive sleep apnea, and others can improve surgical outcomes. Work with your surgeon, primary care provider, and other specialists to make sure your health conditions are optimized before surgery.
Number 6, make sure you provide a comprehensive medication list to your surgeon. Some of these medications, such as blood thinners, immunosuppression agents, diabetes, and weight loss medications, need to be stopped or modified before your surgery. Make sure you understand how to take your medications before surgery, and make sure you know who the providers are that are managing these medications in case your surgeon needs to communicate with them.
Number 7, nutritional optimization. I'm going to repeat, sorry. Number 7, nutritional optimization. Eat balanced meals in the days leading up to surgery. A diet that emphasizes protein and fiber that is low on carbohydrates and fat can support healing and helps prevent complications. Ask your surgeon how long you will need to fast before the procedure. This varies depending on the type of surgery and anesthesia. For patients that are malnourished, your surgeon may recommend additional protein supplementation prior to your planned surgery.
Number 8, exercise. An exercise routine can help you with your hernia surgery journey by improving your muscle conditioning, stamina, and heart-lung functions. Moderate exercises including walking, cardio, running, swimming, cycling, aerobics, yoga, resistance training, and others can help prepare you for the stress of surgery and expedite healing. There are a number of online resources and apps that are specific for hernia surgery that you can search to guide you through this process.
Number 9, reducing risk of infection. Your surgeon may recommend certain steps to reduce the risk of surgical wound infection. This includes showering with antiseptic soap or applying an antibiotic cream to the nostrils for a few days before surgery. Showering before surgery and maintaining good skin hygiene before and after surgery is necessary for optimal outcomes.
And lastly, number 10, mental and emotional preparedness. It's normal to feel nervous or anxious about the surgery. Take time to mentally prepare, whether by learning more about the procedure, practice mindfulness, or speaking with your surgeon. Can help reduce stress and improve your overall experience. Take time to relax, including listening to calm music the night before or morning of surgery. Can help ease the anxiety and support a smoother recovery.
Preoperative optimization is not a Thank you. Preoperative optimization isn't just a checklist. It's a way to take charge of your health and ensure the best possible outcomes for your hernia surgery. By making meaningful changes before your procedure, you can improve healing, reduce risk, and improve your quality of life. Talk to your doctor about how you can be an active part of your surgical team throughout preoperative optimization. Talk to your doctor about how you can be an active part of your surgical team through preoperative optimization. Remember, these tips are general guidelines. Always follow the advice of your healthcare provider. The content of this video reflects the opinions of individual members of the American Hernia Society and does not constitute medical advice. For more information and helpful resources, visit www.americanherniasociety.org.
All right, guys, great job. We have the next session coming in, so we'll mix the practice and this together. If we need to re-record anything, we'll let you know. Thanks so much.
So it appears Santa. Oh, I got one.
You're going in second. Dr. Sassel? Yes, you're going in second. Yes. No problem. I must be.
Yes.
I'm as a. Nice to meet you. Sure. You wanna kick it off and then we'll
Sure.
just take turns. Sully's right there. This is out.
There you go. All right. We're gonna go ahead and get started over here. We have a wonderful session talking about special considerations in hernias and a list of wonderful speakers. So first of all, we will introduce Dr. Richard Pierce. He's an associate professor of surgery at Vanderbilt University Medical Center, and he is here to talk about gender differences in ventral hernia repair.
All right. Okay, well, again, obviously like to thank the AHS for the opportunity to speak to you all today. I have a couple disclosures. Am I hitting the right button? Oh, there's the button. There we go. None of these should be relevant to today's talk. So I'm not sure how many people here know Dr. Melina Kibbe. Maybe several people, maybe not. I don't know. I personally actually have never, don't know Dr. Kibbe and haven't met her, but she's had a pretty profound influence on my recent career and on this talk. Namely, I also, in addition to Vanderbilt, I work at the VA, and I was at the VA surgeons meeting several years ago, and she gave a really fascinating talk about Ambien and how when Ambien was developed, they developed it and released it, and they discovered that soon afterwards, people were having more car accidents after taking Ambien, but it was only in women. They went back to the drawing board and said they realized that all the clinical trials had been done only with male subjects. And as it turns out, long story short, women metabolize Ambien differently than men do, and it tends to have a longer residual effect. So therefore, women were taking it at night, still having a residual effect the next day and having more car accidents. And it just really highlighted how the fact that in science we focus on using men, whether it's animals or humans. And as of 2015, the NIH mandated that all research design had to account for sex as a biologic variable. There's also been previous studies that have shown that women have certain negative effects depending on the surgery they're undergoing. So just to kind of go over this, I think there's already been some talk of disparities, but there are several factors that contribute to disparities. There are the patient factors such as gender, race, age, socioeconomic status. There can be provider factors such as either explicit or implicit bias in us as physicians. And then there are also, of course, healthcare systems factors, depending on where hospitals are located and what insurance they take. And these can all lead to poorer outcomes for patients. So why is this important? Well, obviously, first and foremost, as physicians, we want to take best care of our patients and try to do the right thing for everybody, regardless of their race, gender, or SES. And obviously, also with increased bundled care and reimbursement, that can be largely based on outcomes. So if we can improve those, it's somewhat self-serving, but maybe we can actually get better reimbursement. So furthermore, back in 2016, you'll see that the NIH actually launched this program to reduce disparities in surgical outcomes. And I started kind of looking into this, or more deeply at least, around 2021. And this is my search on PubMed, and my screen's a little small here. But as you can see, it shows only about 33 studies when I did a search for disparities, and thank you very much, when I did disparities in hernia surgery. So I did a talk or two on this, and then I figured, well, now it's 2025, so hopefully we're going to have a whole lot more. And I did the same search, exact same criteria, and we're up to 77. So we're getting a little more, but not a ton more. So fortunately, back in 2018, one of my mentors, Dr. Ben Paulus, and Dr. Sherler and Prabhu wrote a really nice paper that looked at epidemiology of disparities in care, and this addressed gender, socioeconomic status, and race. And it was a really nicely done paper that's a good summary that if anybody's interested in this, you could start with it. But it also highlighted the fact that a lot of the disparity research done, at least at the time, was due to large administrative databases that didn't always include detailed operative data. One such study that is still a great study, been done back in 2021, was a group that looked at using the national inpatient sample, and they looked at over nearly 90,000 hernias and looked at the rates of non-elective ventral hernia repair, i.e. urgent or emergent. And they saw that these are some of the contributing factors, with female sex being one of them. And that when you had a non-elective surgery, that was associated with much higher or higher in-hospital mortality, post-op complications, and extended length of stay. So about this time, as I was getting interested in this, I said, well, I wonder about gender disparities. And I had a really fantastic chief resident named Monica Pulse, who's also here. And we started talking about this, and we said, is there any way that we can look more into some of the operative details that might contribute to this? So we talked about it, and we actually wound up doing a study through the American Abdominal Core Health Quality Collaborative, the ACHQC. And we looked specifically at male versus female patients, and looked at around 27,000 patients that had ventral hernias, either umbilical, epigastric, or incisional. In short, the females were slightly younger, but had higher BMIs and higher rates of diabetes. And some of the results of this showed, it was actually pretty interesting. We saw that when you compared open to MIS hernia repair, women were more likely to undergo an MIS repair. However, they were less likely to receive a mesh during that repair. Interestingly, though, they also were, if they did receive a mesh, they were more likely to get an intraperitoneal mesh, whereas men would get it outside of the peritoneum. And men were more likely to undergo myofascial release. So we see that there are differences to the way that we treat our male and female patients, whether it's purposeful or not. And I will say that this was originally a study that was going to look at inputs and outputs, and it was so large that we actually had to divide it into two. So the outcomes are actually being presented by Dr. Pulse next month as a podium presentation at the ACS. So I'll leave it there. If you want the answer to that, you can just check her out in Chicago. In the meantime, the group in Michigan looked over their Michigan State hernia registry, and they also looked at outcomes with males and females. And they saw that women had slightly larger hernias and that males are more likely to have, than males, and were more likely to have undergone prior hernia repairs. Similarly to the ACHQC study, we saw that female gender were women, were more likely to receive MIS repairs and also had a lower amount of mesh use. But they actually showed that the incidence of 30-day adverse events was 12% versus only 7.4%. So even though the women were younger and had fewer comorbidities in this study, they were more likely to have postoperative adverse events. Fortunately, they also then moved their study along a couple years later and did a similar work within the Michigan database, now looking at 3 more years or 2 additional years of data. And again, looking at complications, and they saw that out of those patients in their database that experienced complications, nearly 60% of those were women. So 60% women, 40% men. They saw that the complication rate was higher in females at 3.3%. And when you stratified that by open versus MIS repairs, the large contributor was the open repair. And you can see that women had a 4.2% complication rate, yet that dropped down to the same as males when undergoing an MIS repair, which seems that maybe an MIS repair could mitigate some of these disparities. So to take a slightly different bend on this, there's a really nice study by my good friend Mazen Al-Mansour. They looked at their institutional database, looking at a little over 5,000 patients to see about patients that actually never made it to surgery because they did not meet eligibility requirements. Those eligibility requirements being things like BMI, active smoking, and a high hemoglobin A1C. And you can see that roughly 10, 9, and 4% of the patients did not meet those requirements. They looked at multiple factors of disparities, and they found that up to 21% did not meet the eligibility requirements to have surgery, and they were less likely to undergo surgery. Notably, 21% of the females had a BMI over 40 compared to only 11% of males. So there seemed to be a higher propensity for that. I think that looking at this slightly differently then, Katie Schlosser and Dr. Hennifer Augustine also did a study looking at their institutional database, looking at fat distribution and hernia size with CT scans in males and females and determining their outcomes from surgical intervention for hernia repair as well. And they saw that females had higher rates of readmission, wound complications, and intervention for pain. And I think it's kind of a funny finding because I know that personally, if I have to operate on, I'm sure it's a bias, but if I have to operate on a man or a woman, I'd rather operate on a woman who has more of the gynecoid body habeas than a guy who has like a really great big belly where I'm fixing that hernia. So I think this is a really interesting finding. And then the last study I'm going to show is, I think, is really interesting as well. The guys down in Greenville, South Carolina always seem to think outside the box. So Carbonell and his group again, used the ACHQC to look at the relationship between surgeon gender and patient gender and the outcomes. They looked at SSOs, SSIs, SSOPIs, and 30-day readmission rates. Obviously, a large cohort of 38,000 patients. There were 266 male surgeons and 61 female surgeons, and they had equal overall rates of complication. And when you looked at the female surgeons, they had same complication rates, whether they operated on men or women. However, when you look at the male surgeons, they had increased odds ratios of SSOs, SSOPIs, and readmission for the females compared to the males. So women basically did worse being operated on by men. So I'm just about out of time, but that's perfect. So what are some of the summaries of this? I think that there now have been several different studies across healthcare registries, whether it's at the institutional level, the statewide level, or the nationwide level, that have shown that female sex can be associated with non-elective repairs, more complex repairs, detrimental effects, and poorer outcomes such as SSO and SSI and recurrence. It's possible that and on top of that, that if this truly is a BMI issue, that maybe more women are not meeting some of the eligibility requirements and therefore not even getting to surgery in the first place. Maybe this will change with the the onset of GLP-1 agonists, but and then MIS hernia repairs do seem to mitigate that somewhat and allow a lower complication rate for women compared to open repairs. And then there's also this idea that maybe female patients gain some additional benefit by being operated on by female surgeons. So maybe we just need to encourage and foster and recruit more women into surgery. So, and I'll end there. Are we doing questions now or at the end?
Do questions at the end.
Yeah, we'll do it at the end.
Sounds good.
Questions at the end.
Next up, Dr. David Santos from the ND Anderson Surgical Oncology Division is going to present to us about umbilical hernias in high-risk populations.
Good afternoon. I am both a member of the American Hernia Society and the Society for Surgery of the Alimentary Tract. This is a joint collaboration that we're starting to try to accomplish year after year. I'll be talking about umbilical hernias in high-risk populations today. How do I do this thing? Oh, here we go. Okay, here are my objectives for my talk today. So a high-risk umbilical hernia is something you know when you see it, but might be very difficult to really characterize more granularly. So just like any other person today, I went to Google AI and said, what exactly is a high-risk umbilical hernia? And this is what it spit out. Somebody with obesity, cirrhosis, ascites, diabetes, smoking, pregnancy, severe pain, bowel obstruction, incarceration, strangulation, and a size greater than 3. So I said, okay, smarty pants, well, how do you fix that then? And this is what it said. Well, you could do surgery. It can be open, laparoscopic, or robotic. Maybe you want to treat it non-surgically, perhaps watchful waiting, lifestyle adjustments, abdominal binders, but definitely please consult a healthcare professional. To which I said, thank you so much for that granularity. I think I'm going to do some more research. But when you really look at this, these are variations on a theme. When you look at size greater than 3, that speaks to the theme of tissue weakness, which brings apart the idea of whether or not you should use mesh for your surgical technique. Obesity, ascites, and pregnancy speak to the idea of an increased abdominal pressure, and makes you think about doing preoperative weight loss, ascites control, and childbirth. The current recommendation for weight loss is negative 10% of their total weight loss, or achieving a BMI less than 35. And for ascites control, you want to maximize the aldactone, the Lasix, maybe consider a pre-op paracentesis or a TIPS, depending on how severe it is. And then if the woman is pregnant, perhaps definitive repair after childbirth versus something temporizing. And of course, for smoking, stopping 4 to 6 weeks prior to surgery. Regarding diabetes and nutrition, this speaks to the idea of impaired wound healing, and the current recommendation is a hemoglobin A1C less than 8 and an albumin greater than 3.5. And obstruction, strangulation, and incarceration speak to the idea of an impending surgical emergency and whether or not you should do something temporizing versus definitive. And most would agree that if it was something not effective, perhaps a definitive repair is okay. I was being a little cheeky when I talked about AI, but this is actually a true story. A patient put all of his factors into ChatGPT and said specifically, what are the questions I need to ask Dr. Santos at my surgical consultation today? And it spit out this list, which he gave me. I'm not going to belabor you with the list, but these are the things he was asking me. He said, given my cirrhosis and prior paracentesis, are you going to repair both my umbilical and inguinal together? Is there any special management before or during surgery? And how does my immunotherapy impact my plan on recovery? Do you have any cases or similar outcomes that reflect my concerns? So the umbilicus is really the downtown of the abdominal wall. It is a site of tissue weakness prone to herniation from increased abdominal pressure, and it is prone to wound healing issues because of its compromised blood supply from the superficial collaterals and the very small deep branches of the right and left deep inferior epigastric arteries. It is also the second most common site of incarcerated or strangulated hernias requiring emergency surgery. This is the very definition of a high-risk surgical area. So as hernia surgeons, our ultimate outcome is to create a pathway such that we develop no recurrent hernias, or at least very few of them. And that requires us in very technical circumstances to look at suture repair, whether or not you need mesh, a component separation, or whether or not it can be done minimally invasively. But I'm here to tell you that chronically ill patients have a competing outcome. And that competing outcome is oftentimes their survival. If their survival is short, the goal then becomes minimize the complications to improve their quality of life, which may make you focus on solutions that are probably simpler, but maybe not as long lasting, such as suture repair or plus minus mesh. And if they have a longer survival, then you can consider things such as component separations and minimally invasive techniques, with the goal being minimal disruption to the other therapies that are prolonging their survival. And it's that delicate balance that you have to achieve when you're looking at very different populations, or high-risk populations, as to say. Hello? Okay. In my mind, the surgical considerations for hernia repair in cancer patients are 4 very big topics. The first one being healing. In patients that are neutropenic or having an absolute neutrophil count less than 1, you need to be careful about operating in them, because there is a 55% chance of morbidity in this patient and a 12% chance of mortality. So 2 out of 10 patients will die if they are neutropenic when you operate on them. And of course, this number goes up acutely in the acute situation. The things that affect this are things such as chemotherapy and immunotherapy. Regarding bleeding, this is much the same as you would handle in a non-cancer patient. You want platelets greater than 50 and an INR that's acceptable. But you have to remember that many of these patients are going to be on oral anticoagulation for other factors, such as perhaps a splenic vein thrombosis. A lot of times we think about functional status in the sense that of their ASA score. However, in cancer patients, they are almost always an ASA of 3, so that's not really super granular for us. However, the oncologists kind of have us beat in the sense where they grade these patients based on the Eastern Collaborative Oncology Group score, which really grades how active the patient is. And that's actually something more useful to us as hernia surgeons. An ECOG of 2 is probably where you want to stay, which means that the patient is ambulatory for more than 50% of the day. And lastly, prognosis. This is very hard to figure out. And you need to make this decision with the oncologist. And to be truthful, sometimes the oncologist doesn't know either, because prognosis that may have been one time very high, very low a couple years ago, and now is going to be very high, really depends on how they've advanced the treatment of cancer in these patients. A lot of cancer treatments are now based on biology. And so that means a lot of times the prognosis is not very well characterized. For hernia surgeons, you want to know the degree of peritoneal involvement as we move to more peritoneal-based repairs. And I want to introduce the idea of circulating tumor DNA. This is the idea that although these patients might be negative on their imaging and for all intents and purposes, no evidence of disease, they may have a blood biopsy that shows that they have tumor DNA circulating in their blood. And it then becomes not whether or not the patient will have cancer, it's when the cancer will return. So that's something to be aware of as cancer technology advances. In my mind, there are 3 very basic classes of chemotherapy drugs you need to know about. It is impossible to memorize all chemotherapy drugs. I've spent the better half of a decade plus trying to do that. But I do think as time has moved on, this is the current trend. The first class of immunotherapy you need to know about are checkpoint inhibitors. And what these really do are they prevent the immune system from attacking healthy cells. But the side effect is actually something you need to know about. They cause endocrinopathy, things that affect the pituitary, the thyroid, and the adrenal gland. And the implication to you is the hemodynamic stability of this patient. They might be Addisonian. Additionally, if they are hypothyroid, they may not heal very well. But surprisingly, you don't have to hold this med prior to surgery. They might actually continue this prior to operation. And the medications that are commonly associated with this right now are pembrolizumab, nivolumab, and ipilimumab, things that are associated with melanoma. In contrast, the VEGF inhibitors are absolutely things you need to hold before surgery. They inhibit angiogenesis and have a paradoxical effect on wound healing and paradoxical bleeding. The most notorious of this is bevacizumab or Avastin, commonly associated with colorectal cancer, and sunitinib, pazopanib, and sorafenib are associated with renal cell cancer and thyroid cancer as well. And lastly, the blood cancer medications. These target B cells, which by very definition are neutrophils, and they will lower the absolute neutrophil count. And these also need to be held prior to surgery, the most common of which are rituximab and ibrutinib. So let's apply this information. You get this patient, same guy from AI, 55-year-old man with hepatocellular carcinoma. He comes to you for an umbilical hernia repair with ascites. In 2023, he had yttrium-90, which is radiation to his tumor, and then got bevacizumab, which is a VEGF. He had refractory disease a year after, and they gave him more bevacizumab and radiation. And then he got durvalumab and tremelimumab. I was not kidding when I told you you cannot keep up with these names, but I do know these are checkpoint inhibitors, so it's probably not something you need to hold. He then developed portal hypertension, cirrhosis, esophageal varices, a splenic vein thrombosis, umbilical hernia, and a right inguinal hernia. Surprisingly, no bowel obstructions, no abdominal surgery. MELD is 10, which is low. Child's P class is A. ANC is 2.7, platelets are 96, INR is 1.33, and the dimensions of his umbilical hernia are 2.5 by 2.5. He has an ECOG of 1. How are you going to manage this very perfect specimen of a surgical candidate? Well, I think we can operate. His healing, regarding healing, his ANC is greater than 1, and we really don't need to hold his immunotherapy. Platelets and INR are adequate. He has a good functional status. He looks scary, but he's actually not so bad. In terms of his prognosis, we don't know what his prognosis is, but we do know from many studies that a planned surgery is probably better than an emergent one, and his surgical risk is actually relatively low given his disease. So once you figure out those factors, then you follow your basic hernia principles, and these were based off the European Hernia Society guidelines. So you're going to definitely put a mesh in this patient, and you're going to tailor the approach. And then you might or might not use a slow reabsorbable suture, a mesh that's permanent. You're going to try to put it in the preperitoneal space and use an MIS technique if it's greater than 4 centimeters. And as I said before, probably better to do something elective or emergent. And with that, I will hand it over to the next speaker. Thank you. Oh, all that, yes. Okay.
All right, next we have Dr. Sheen, who is affiliated with the Fortius Clinic in London and Manchester University. He'll be presenting on the robot is broken, laparoscopic strategies for inguinal and ventral hernia repair.
Thank you, chairpersons. Ladies and gentlemen, I'd like to thank everyone for the invitation. Yeah, I'm going to academically destroy the robot, so sorry about that. These are my disclosures. Whenever you talk about anything, you have to go back to basic principles. This is the first thing we learn in first MB or, you know, your first year at medical school is the ABCs, and that's what we're going to discuss here. We know what's happened over the years. Bassini started it all, and now we've moved on to robotic tap. These are all the milestones that I feel that are important. But do you actually need the robot in hernia surgery? Yeah, I think that debate should be thrown wide open to this audience. Yes, the robot's innovative, it's three-dimensional, helps viewing, improved dexterity, finer controls. But are your patients actually asking for it? Are they actually coming to your theatre and saying, I would like you to repair my hernia with a robot? Or is it just mainly chest beating surgery? So let's go to ABC, and I feel the A should be the anatomy, which I will discuss both in inguinal and ventral, pros and cons, robot and no robot. Benefit, is there any benefit? Cost effectiveness, I think you already know the answer of that. But you can go on, you know, I do know more of the alphabet. D, you can say dexterity. E, ergonomics. F, failure. I'm not going to discuss D, E, and F. That may be an opportunity for another debate. So the Rivals trial study was an important landmark, Cleveland Clinic, good study. Robot offers no clinical advantage. Same outcome, recurrence, pain, but a longer OR time. So this supports laparoscopy as the most cost-effective way of repairing an inguinal hernia. I think that's possibly reasonable. These are the outcomes. The ones in the yellow are the ones that I'd like to have a look at. It's similar, robotic tap and lap tap in terms of the pain scores. It's similar. More importantly, can your hospital afford it? If you go to any hospital in the UK, they say, yes, we'll get it, but they can't actually afford it. So what are the alternatives? The laparoscopic tap or tap, there's no need to discuss those. So let's look at the anatomy and the difference between laparoscopic and robotic. So visualization, you look at mesh placement and suturing ability. And here is where the robot has a slight enhanced effect. The wrist motions, the dexterity, the ergonomics and suturing. You can suture with your left hand. You can suture with your right hand. So in terms of anatomy, identification, 2D and 3D, there isn't any objective clinical evidence to say it will make a difference. Look at the scars. This is an actual elite athlete that I operated on doing my usual TEP technique. You can hardly see the scars. And a laparoscopy, you'd have a 10 and 2 5 ports. For robotic, you've got a 10 and 2 8s. Some of you will do it with 3 8s, but the median is greater and also the mean is greater. We're very pictorial people, surgeons, so you have to put a video in. Otherwise, you'll all fall asleep. This is me doing an incarcerated hernia. And I was reliably told, sorry, I'm just mid-50s, need these, that I can forward this to the important bit. Do you know the femoral hernia when it pops out? That's exciting, isn't it? And that's the bit. You can watch this on YouTube. I don't watch my own videos on YouTube. I watch reruns of Blackadder Goes Forth. I don't know if you know that, but that's far more exciting. And then it comes out, then a little bit of fluid came out. And I actually presented this at the British Hernia Society, and they asked me one question: did you not need to give antibiotics because of the fluid? But I believe the fluid is sterile. So I'm going to move on, if that's okay. You're welcome to go, but removing that incarcerated hernia is brilliant. And you can do it just as elegantly with a robot. What are the different types of robotic ventral techniques or different types of ventral hernia techniques? These are all the techniques. If you look at laparoscopic IPOM and robotic TAL, in yellow, I've put bits that are important, why it matters. Robotic has been shown to reduce the risk of bowel injury. Okay, robotic also allows midline closure in ventral. So anatomically, that midline closure is easier in robotic. So the dexterity is better. Ergonomics is better. See, we're going on to D and E. Let's stick to A, B, and C. So mesh plane matters. Laparoscopic IPOM, simple. Robotic, you have to do retromuscular, although the another study, which I'm going to mention, looked at robotic IPOM. Robotic excels in defect closure. Anatomically, that is where it excels. Safe adhesiolysis as well. So the Prove It randomized control trial looked at intraperitoneal mesh placement, robotic versus laparoscopic. This trial did not report long-term outcomes specifically related to mesh bulging. And that's where people feel that because of the closure of the midline is more superior with the robotic, it should make a difference in terms of mesh bulging. It didn't report it. It didn't show it. It didn't show a difference in complications. It showed an equivocal result, and the robot was more expensive. So laparoscopy excels in intraperitoneal ventral mesh fixation, while robotics may improve retroperitoneal dissection. 2D or 3D makes no difference, but there's no existing evidence to say it is worth doing in inguinal surgery. The benefit, possibly reduced in terms of post-operative pain because of wristed movements, but it has not been shown to be the case. Learning curve obviously is steep. And in terms of ventral hernia, the operative time is certainly longer. But again, there was no obvious benefit in looking at all of those parameters in the data that we have today. So the benefit, inguinal, no clear superiority. Ventral, ergonomically, might be a little bit better, but laparoscopic remains fast enough and adequate for simple hernias. Maybe for more complex hernias, data is emerging where robotic has a proven benefit. Cost. This is a no-brainer. You can't do it. You just cannot match the cost. You see, it's twice the cost. And that has been shown in procedure, theatre utilization, and the time upfront in terms of theatre preparation. These are the various laparoscopic techniques that are present, which are minimally invasive. But again, if you look at the red differences, procedure costs, higher. Theatre time, higher. Sorry, OR time, higher. Mesh supplies, higher. The only one that is equivalent is the hospital stay. Only one. Readmission, total index stay, higher. Sorry, readmission was lower for robotic. That's not been explained. In terms of cost effectiveness, we're still on C. Hospital stay, it's a draw. But everything else, the winner is laparoscopic. So laparoscopic wins, even for robotic ventral surgery. So in terms of C, cost, Rival study and the other data that we have from the Prove It study, both from the Cleveland Clinic, show that it's no good. So in terms of healthcare in the UK, I mean, You know, I live in a circus. The only reason I know that is because there's clowns running the country and they just don't listen to you. They don't listen. I worked in the National Health Service for 31 years. I left a year ago and my wife even says, you look normal. I actually am a natural blonde and I've dyed it gray just to fit in. That's how bad the NHS is. It's not worth it. They don't listen, but you had the Affordable Care Act. And when I actually read about the Affordable Care Act, it actually made sense. But why are you going to do something that makes sense? Ditch it. Let's go back to charging everyone what we like and leaving some people without any healthcare. So dilemmas. Robotic surgery was seen as a priority by surgeons, and it's seen as a luxury by physicians. Is that the case? So we have to have a balance. There's a lot of kit. What we need is more randomized controlled data. The main issue is the cost. Who's going to pay? Patient, insurer? Money will come from somewhere, maybe a tariff. It's a good word, that, isn't it? We actually, some people were spelling it with one F. It wasn't just your president. This is what a robot looks like. I used this robot. I did about 25 cases inguinal hernia. It's very nice, very exciting. As you can see, the nurse was horribly excited and decided to go back to India, and I think she has now. These are the incisions that we use. Absolutely fine, no problems. They're exactly the same. So the forward plan, inguinal hernia, the jury is still out. Robot is still there. I feel we should carry on and embracing technology. And which better country to do it? The richest country in the world. That's you, by the way. Ventral hernias, complex cases, it appears to show some sort of effect. And I feel the dexterity, it will help. And I think robotic cases will help in the future. So that's the plan. So laparoscopy, yes, it's good. At present, the robot remains an adjunct only. Data will continue to steer best practice. And that's with absolutely everything you know. And show data to a hospital manager. Good luck with that. Absent friends, for those of you that have had the privilege to read my book, All the Money Goes to Charity, page 142, I describe a comical event with a fellow Brit at a meeting in Berlin. It's sad, but I'm also very pleased to report that person was Neil. And at the beginning of the book, I do say I do not disclose anyone's names, but it was Neil. And I think I'm going to have to write a second edition and put Neil's name in the book. May you rest in peace, my friend. Thank you very much.
Right. Next up, we have a topic that many of us are familiar with. This is Dr. Brent Matthews. He is a chair at the Department of Surgery at Atrium Health. He's also a past president of AHS, and he will be talking to us about hernias on call.
Good afternoon. Should have had a couple beers at lunch so I could be as funny as the last person. That was excellent. I don't have any disclosures. This talk will concentrate on ventral hernias. I hope that you'll have some take-home messages. If you look at the burden, if you use a score to define operative emergency general surgery burden rank, ventral hernia ranks as the 11th in terms of combining mortality and morbidity, although it's the 6th most common reason a patient will undergo surgery in an emergency general surgery setting. As the hernias get more complex and they require patients to be triaged and transferred throughout the hospital systems, this is a real problem. 1 in 10 patients in the United States don't have access to emergency general surgery capabilities, and 1 in 4 patients experience low access to hospitals with advanced clinical resources. And you can imagine the patient populations that are most vulnerable of not having access. So the management of ventral hernias and the problems that patients experience can be exacerbated. The first rule of thumb when you're managing a patient with ventral hernia in a situation that's an urgent or emergent environment is you got to be a surgeon first and worry about the hernia second. This is an example of a patient who came in, has a bad soft tissue infection related to perforation from a hernia. This is drain the infection. This patient developed a fistula and then had an interval operation in the future. These patients are often clinically ill, physiologically challenged. So trying to do a definitive hernia repair on this patient is not the right action. And then even when they do have a primary hernia problem, this is a patient who came in through the emergency room. Sometimes you got to do a lot to these patients. This patient required exploratory laparotomy, lysis of adhesions, a colectomy. The colostomy had to be resected and resited. They had to have their hernias fixed. And you just have to accept the fact that 12 months later, this patient's going to have a really complex hernia. But again, this is really about getting the patient out of trouble. It's interesting, this may be a more common problem you see in the emergency setting, certainly with the increasing use of prehabilitation or optimization of patients. In this randomized controlled trial, it was 5 times more likely that a patient who was enrolled in a randomized trial of standard counseling versus prehabilitation, that the prehabilitation patient would present requiring emergency hernia repair. So this window of time that often isn't very standardized and very ill-defined of when patients are clearly optimized, can undergo surgery, the patients can actually have an event. And I thought this article from in the Hernia Journal in 2024 had a actually provocative statement, but a statement of reality. And that is, while there's no question that modifying these risk factors can improve the patient's overall health, the hernia-specific data simply does not justify prolonged waiting or even denying surgery and patients fail to achieve full optimization. With patients continuing to suffer while in the waiting period, one wonders whether they're truly helping or perhaps is serving them by continuously kicking the can down the road. And as somebody who takes almost exclusively emergency general surgery call, I don't take trauma call or critical care, and do some elective surgery, this is actually a real common scenario that we see patients in these optimization programs who fall out. And then you have the group of patients who you've identified that they have a high comorbidity burden. You make a decision not to operate on these patients. And then what do you do when the patients show up in the emergency room? And in this population-based study, patients who were in that cohort who actually showed up into the emergency room with an incarcerated hernia had a 7.5% 30-day mortality, a 10% 90-day mortality, and a 14% one-year mortality. So these events actually are can be quite life-altering for this patient population. And so it makes you rethink, what do you do with these patients when they actually do show up in the emergency room? Because this study here shows that a high majority of these patients will actually be readmitted in the hospital within a 1-year time period. So this becomes a cyclical event. And each time they have this, obviously, that there's a physiologic burden to that. And so being a little bit more aggressive up front may prevent the patients from getting into this cycle of events and having an ultimate demise through a condition that has solutions. The other thing you have to remember is that many patients show up with gastrointestinal emergencies in the face of having a complex abdominal wall hernia. And how do you manage these patients? This is a patient I saw in the office, a flank hernia, kind of an unusual hernia. This is the pre-op CT scan. And then between the time I saw him in the office and 4 weeks later and he was to be scheduled, he showed up in the emergency room 2 weeks later with acute appendicitis. And this is a CT scan from his appendicitis. So using the principles from the CODA trial, treated this patient non-operatively, had an appropriate Alvarado score, no appendolith, and was treated successfully non-operatively. And then we operated on this patient about 6 to 8 weeks later. So there are other multiple gastrointestinal conditions that patients will show up for with an urgent emergent problem, whether that's diverticulitis, that you can treat non-operatively and you don't need to operate on them and disturb the hernia. This patient here had a perforated duodenal ulcer, placed a nasogastric tube, drained the fluid collection, didn't have to operate on the patient. And then this patient on the right-hand side of the slide who had a small bowel obstruction, you couldn't tell whether it was related to the hernia or not. Had a gastrographin study and passed that and didn't require operative treatment. So there are many patients with these complex abdominal wall problems that show up with a different problem. It's not related to the hernia that you can treat non-operatively. Again, as somebody who now takes emergency general surgery call, I appreciate more the algorithms that are used in these patients. I'm in a call group with 10 other people. We have different experiences, different skills, different talents. And we hand off patients between each other all the time. That's the life of an emergency general surgeon. So these algorithms help us to have less heterogeneity as it relates to how we manage the patients. This is published in the Journal of Trauma and Acute Care Surgery. It is an algorithm about the evaluation of the patient, diagnostics and so forth, and then about repair strategies for the patients. The other thing that we've implemented in our emergency general surgery patients is enhanced recovery after surgery. So using these enhanced recovery pathways in this population is actually, as a whole in this population, had dramatic effects as it relates to the length of stay and 30-day mortalities. We don't have enough patients yet in the ventral hernia cohort to know if it has an effect on that particular group of patients, but we tend to use these principles in our emergency general surgery patients as well, and whether that's around pain control, whether it's around mobility and some other things, you can actually do these things early on. You have to remember that there are high-risk features that patients will present with when they have ventral hernias, high-risk features of strangulation, and even high-risk features that they may get a recurrent hernia. And these could be triggers for being more aggressive when they present. Of course, with strangulation, many of these are radiographic based, but some high-risk features that the patient will return with a recurrent problem from their hernia and could be in the strangulated category in the future. In terms of what's the landscape of emergency general surgery care in ventral incisional hernia patients, I'd say it's where ventral hernia repair was probably 15 or 20 years ago. We need better definitions. We need databases to be able to track these patients to know that our care pathways and our algorithms are actually impactful. This is already being done. This is in Europe. It's called the ACTIVE trial, and they've started to show some definitions of minimally invasive being better than open surgery, and its surgical approach may matter. And this is an example of a patient who came in who in the past probably would have gotten a laparotomy. We stuck a laparoscope in. You can see this piece of bowel looks at risk. And 30 minutes later, that bowel looked like it was viable. We closed this hernia percutaneously. Yes, this patient will probably get a hernia in the future, but this patient's out of trouble. This is from the Michigan Surgery Quality Collaborative, just looking at how are people managing hernias, whether they're primary recurrent ventral hernias. And it was interesting to see that still the vast majority of these are being open, but mesh is being used much more commonly than I thought it would in these conditions. And the last thing I want to talk about with mesh is the use of mesh. You have to be careful about using this when it requires an organ resection. So whether that's small bowel resection, colon resection, often things that often get incarcerated or strangulated within these hernias. But overall complications in the mesh group will be higher than primary repair with organ resection. And if you just look at the cohort of everybody had mesh, if they didn't require an organ resection, those complications were higher. And then the technique that you use to place the mesh can actually have an effect on outcome. In this population-based study out of Denmark, demonstrated that retromuscular repair, so you're making myocutaneous flaps, has a higher wound morbidity rate when using mesh than if you do those myofascial releases. Thank you very much.
All right, next, Dr. Celia Ledet from, who's an associate professor at the Department of Surgical Oncology at MD Anderson, is going to give us a talk on the considerations and solutions for oncologic patients and hernias.
So thank you. I'm an associate professor within the Department of Surgical Oncology, but I'm a general surgeon. There are two of us within the Department of Surgical Oncology that perform nothing but non-oncologic general surgery. About a third of our practice is abdominal wall reconstruction, and out of that, about a third of it is robotic. So it's a very interesting patient population to talk about. So today I'll be talking about the incidence of hernias in our cancer patient population, and I'll talk about some of the hernia patterns that we see within our group. I'll then go over some preoperative clinical considerations that we use in order to figure out what type of hernia repair each patient will need. And then I'll go over some case scenarios that we commonly see at Anderson. So why is this important? Approximately 60% of cancer patients will require some type of surgery during their treatment. And a significant portion of those patients will require abdominal pelvic operations. The common cancers that we typically see in our practice are colorectal cancers, hepatobiliary cancers, GYN and urologic malignancies. And we do see a lot of others, but these are the most common solid organ cancers. Patients not only have surgery, but they also have adjuvant therapy. They undergo neoadjuvant therapy, and all of those things can increase the rate of postoperative ventral incisional hernias. And these hernias do occur quite often in our group. We have a plastic surgery department that also does abdominal wall reconstruction and that group consists of 22 surgeons, and there's 2 of us, and we're all extremely busy. So hernias can cause obstructive symptoms in our patients. They do cause quite a bit of pain, and also they can really diminish the self-image of some of our cancer patients. So this is a study that looked at patients who underwent general abdominal pelvic surgeries in cancer patients. These patients were followed over 2 years. And the incidence of ventral incisional hernias after just regular elective surgery is about 10 to 23%, but as you can see, it's a lot higher in cancer patients. 41% of this group did develop a ventral incisional hernia, with those that underwent hepatectomy getting hernias a lot more often. So this is one of my favorite slides because it essentially just shows the common hernia patterns that we see in our practice. So I'm going to start with patients that have liver and colorectal metastases. These patients often develop iatrogenic Morgagni hernias at the top of the midline incision. These patients often also have Makuchi incisions, so that's basically a midline laparotomy with a right lateral extension. We do see quite a few hernias at that confluence of that incision, so right at the umbilicus. We also notice that whenever we're doing preoperative planning, we notice that the right rectus is typically atrophied because of that right lateral extension. So we see hernias in the midline, at the umbilicus. Sometimes we see them all the way on that right lateral confluence as well. So for colorectal cancer patients, some patients still do get open surgery, but we do have a lot of patients that have that undergo laparoscopic or robotic incisions. The majority of these patients that we see peristomal hernias typically at the stoma sites for patients that have APRs. We also see peristomal hernias at those that have ileostomies. And so those are the common hernia patterns that we see in colorectal cancer patients. In endometrial cancer patients, those patients often come to us preoperatively. One of the major risk factors for developing endometrial cancer is obesity. So these patients often come to us with BMIs greater than 40. They have umbilical hernias, either primary or from a previous surgery. And then also postoperatively, we see them because they develop ventral incisional hernias at their extraction sites in the midline. We also see quite a few patients that have had gastric or pancreatic malignancies. Typically, they also have midline hernia defects. And one of the things that we always think about is patients that have had previous J-tubes. When we are doing our preoperative planning, we have to realize that the jejunum may be tented to the anterior abdominal wall. So very important when we are gaining access to the abdomen to make sure that we don't go through that site. And also making sure that we take down that tented up jejunum to the anterior abdominal wall and oversewing that. Lastly, we have a very robust urology department at MD Anderson. We do see their patients because they're midline extraction sites. Sometimes with their closure techniques, we often have hernias there. At that point, sometimes we see them postoperatively and we just electively repair them, but we do get called in intraoperatively when they didn't realize a patient had a hernia. And we have to decide at that time if we're going to repair the hernia or if we're going to give them if we're going to do a definitive repair, if we're going to just do a primary repair. And then also, because of the extensive pelvic dissection, we often see patients with inguinal hernias postoperatively. And then lastly, we do see quite a few patients that have had large retroperitoneal sarcoma dissections. These patients often develop midline incisional hernias, but also sometimes their posterior sheath elements are missing, and so we have to reconstruct that. And then we often see these sarcomas extending into the inguinal canal, so sometimes we have to reconstruct the inguinal canal after large sarcoma excisions. So this is a busy slide, but it kind of goes through the normal treatment algorithm of a solid organ malignancy. Not every patient gets every treatment, but this is just kind of a normal treatment algorithm. And these are the things that we have to consider whenever we see patients. So usually if we see a patient that has just been diagnosed with the cancer and they have an incisional hernia, we look at their comorbidities just like we would for any other patient. For patients that have been diagnosed, that have gotten neoadjuvant therapy, and they're going to have a surgical resection, we have to figure out if we need to do the hernia repair prior to their surgical resection. Then we have to figure out if they're going to have a surgical resection, is it okay for us to do a combined resection? And that basically will leave the patient on the table for a prolonged period of time. So we have to think about that. We have to think about also the type of surgery that's being performed and if it's going to be contaminated, if we want to really do a hernia repair at that time. If they're getting adjuvant therapy, as David alluded to, we have to think about what type of therapy they have received. Do they have a safe treatment window? Are they neutropenic? And then also, if the patients are going to have future therapy. This is really relevant in the sarcoma patient population in which the treatment for sarcoma is additional surgical resection. So if we fix the hernia, are they going to have another another surgery in the future necessitating surgery? And then we always think of the side effects of therapy, and we always think about patient functional status as well. So there's quite a few things that we have to think about whenever we are treating our patients, and we really collaborate quite a bit with our oncologic colleagues. So who do we repair? Strangulated hernias and any patient that has a current or previous history of incarceration. And then specifics to cancer patients, is this hernia impacting their quality of life? Are they in pain? Do they have poor stoma appliance fit issues? Do they have a poor cosmetic appearance? And also for patients that are going to have radiation, if they have lower midline hernias in which there's a lot of bowel contents, do we need to repair that before they have radiation? So when we do the repair, we use normal principles of hernia repair, and essentially if we can use mesh, we do. We obviously like to get the fascia closed, and that may or may not require component separation. Ideally, we like to place the mesh in an intramuscular position, and if we can, we will do this robotically. So I'm not going to belabor this point. Everybody has seen this slide, basically demonstrating abdominal wall anatomy and showing the location in which we normally place the mesh. So these are some common cases that we see at MD Anderson. These patients can be very complex. This is a patient with stage 4 sigmoid cancer, had an open sigmoidectomy, also had adjuvant treatment. He also had a 2-stage hepatectomy. He came in with a retroperitoneal lymph node that was of concern, and he also had a ventral incisional hernia, as you could see from the CT scan. So we ended up doing a combined retroperitoneal lymph node resection, and then we also did a bilateral TAR. This is just the video from the postoperative video after that case. Everything is nicely in place and repaired. The next slide is a patient who had endometrial cancer and also had a ventral incisional hernia. She had developed a port site hernia, but her BMI was 48 at presentation. She was referred to an outside hospital for bariatrics and medical surgical weight loss, and she ended up getting having a small weight loss. She came back with a posterior vulvar mass concerning for malignancy, and also had incisional hernia-related pain, and we ended up doing a robotic-assisted intraperitoneal underlay with separate mesh, and the GYN team did a combined vulvular mass excision. And lastly, this case is just to demonstrate that sometimes the posterior elements are gone after oncologic resection. This is a patient with a malignant teratoma of the ovary. She previously had a XLAP and right salpingo oophorectomy. She developed a right lower quadrant metastatic peritoneal nodule that was present on PET scan. She also had a pretty large ventral incisional hernia with associated diastasis. The GYN team took her to the operating room and performed a right lower quadrant peritoneal nodule excision and left a pretty large defect in the posterior peritoneum, in the posterior sheath, excuse me. We ended up actually having to do a TAR for this patient, and we had to use a biologic bridge because the portion of the posterior sheath was missing. So in conclusion, cancer patients do have a high incidence of postoperative ventral incisional hernias, and those hernias are typically repaired in order to improve quality of life. And the hernia repairs can be performed anytime during their cancer treatment. And ventral incisional hernia repairs in cancer patients may require multiple repair techniques for complete abdominal wall reconstruction. Thank you.
Next will be Dr. Upal, who is an assistant professor of surgery at Emory University. Will be giving us a talk on management of abdominal wall peritoneal metastasis, palliation, and reconstruction.
All right, folks, thanks for joining us. And appreciate the opportunity to talk. I'm a colorectal surgeon and surgical oncologist, and a lot of my practice is these locally advanced tumors, and I think it's an interesting thing to deal with. I want to share some of our work we've done along with my colleagues. No disclosures. So when we think about abdominal wall metastases, there are a couple of things we want to think about in terms of what's causing them, what's the overall patient prognosis, and is surgery going to help them or not. So you can get metastases that go into hernias, especially from peritoneal disease. They may or may not involve the actual peritoneal lining. They could just be hanging out in there, but you have to think about that in the context of a hernia repair and SI reduction. You can also get incisional metastases. So these are basically, they've had a primary resection or a prior site reduction, and now it's kind of the tumor's regrown in the scar of the prior laparotomy. Or you also get port site recurrences, especially with appendiceal or other mucinous tumors. You tend to see that. There's also, some things that don't necessarily need operative intervention. So, Sister Mary Joseph nodes from lung cancer usually need to treat the underlying cancer, and a lot of times these will improve in terms of symptoms. Same thing with sub-Q or cutaneous metastases, especially from renal cell. A lot of times these will all go away with immunotherapy. We'll just go through a couple of different scenarios just to have an idea of what we're talking about here. So this is probably the most common of the scenarios that you'll run into. This is a recurrence within a laparotomy incision. You can see that most of the rectus muscle is still uninvolved, and it's really along the scar. It's extending into the peritoneum. Maybe there's some small bowel that'll be involved when you get in there. That's an important thing to think about obviously is what organs are involved in these metastases. This is another pretty common scenario too, is where you have these omental mets, but they're actually not involving the abdominal wall. You have to be prepared, okay, what if they are? You may have to take some of the posterior sheet to get these cleared, but they're not as big a defect as you would with a full thickness involvement. This is a case of mine that I'm actually operating on Wednesday. It's a kind of special situation, right? So this person has a sigmoid tumor. This is a tumor here with some central necrosis. It's perforated into the right rectus, relatively low down. And then the other thing is that this is also abutting the right psoas. I don't show it on the cross-sectional, but on the sagittal, you can see it here. So this can be a little bit difficult because now it's stuck to two places. One is stuck to the abdominal wall, and then it's also stuck to the retroperitoneal structures. So that's a whole thing. But it's still resectable, and through Ural's magic is actually reconstructible. So separate from the anatomic considerations, you have to think about the oncology. You know, how much disease do they have? What's their survival? And then what are you trying to do here? You know, there are a lot of scenarios where people even with peritoneal disease have a really long survival. And that's something to keep in mind, that it's not just about, you know, slamming in cycle after cycle of systemic therapy to keep them alive. You have to have them in a reasonable condition and keep the patient in mind, not just knocking out disease. And this is especially important with these type of metastases because certain biologies, they'll actually ulcerate through the skin. And now you have basically an uncontrolled wound. That's a big problem, and they can't really get much systemic therapy except sometimes immunotherapy. But a lot of the cytotoxic chemos, you're done. That's not going to be happening. And so you want to get these before they become the big problem like that. You know, there are a lot of preoperative considerations, which you all are quite familiar with. I think the main points I would say here are that these partial SBO symptoms are very common. They're not necessarily because of the mets that you see on the scan, but they're smaller mets that are along the serosa. And sometimes they have to be on some kind of liquid nutritional supplements to get them to a condition where you can't operate on them. Functional deficits, that's a big concern that patients have, and that's actually pretty well tolerated. There are several studies that looked at looking at VRAM flaps and other types of rectus-based flaps and seeing what the outcomes are. And I used that as a substitute for these abdominal wall resections that we're doing. You know, unilateral rectus muscle loss is pretty well tolerated. There's a relatively high rate of recurrent hernias, which is not surprising. And then obviously if you have bilateral muscle loss, then you have some reduction in trunk flexion, but people actually do relatively well in their overall quality of life. So the operative plan, we kind of touched on these points, but main thing, how much bowel is involved? You know, is their bowel going to be stuck to this met that you're going to be taking out? Location, how thick it is going through the abdominal wall and what parts of the abdominal wall are going to be coming out, including potentially some skin. And you know, I would say patients who've had a prior laparotomy, regardless of what the CT shows, they almost always have involvement of the fascia. So you just have to accept that that's going to be happening. And then the other thing is the longitudinal transverse. So, you know, with colorectal surgery, a lot of times we do these low transverse kind of C-section peering in, fan steel incisions, which is all fine and good. But if you have tumor seeding of that fascia, now you have a big problem because now it usually spans both sides of the rectus. There is no posterior sheet down there. So now you have a kind of a problem. And that type of repair, which is a similar scenario to the CT I showed for the guy for next week, is usually going to be some bridging mesh that you're going to have to put in. It's going to be hard to get that close, as you all know. All right, so now I'm going to show you some diagrams that I drew. Just bear with me. I'll try to explain what they are. All right, so patient's head is over here on the right. legs on the left. Here's our tumor, right here. And then say you start out, you open the, upper midline, say this is a lower midline. You open upper midline, there's omentum below you. You start, one thing that I do is try to figure out, what muscle can be spared and what fascia can be spared. And if you just kind of chomp through all of this with a ligature or something, you're gonna lose way more tissue than you really need to. So I'll generally continue this midline incision down to a little, leaving some margin, cephalad to the tumor, and then incise around the anterior fascia and start retracting that, and then figuring out how much of the posterior fascia is involved. And the reason I do that is you want to minimize how much fascial loss you have. You all know that. So if you do this well, you can have a pretty small rim of fascia that you have as your margin. You're going to lose some rectus also, but you can stay pretty close to these. The peritoneal metastases don't need a huge margin of resection. Basically, you just need a grossly negative one. This is true for regardless of what biology you're looking at. So now you choose one side to free up fully. So you're going through the posterior fascia. In this case, obviously this is below the umbilicus, so there's not going to be a posterior here. But you go down through the abdominal wall, and if you do it well, you can now flip up the tumor, all the tissue that's going to be going with it as a margin. And if there's some momentum or bowel stuck, now you can see it much more clearly and dissect all of what is reasonable to dissect and take what's reasonable to take. But you spare a lot of the problems in terms of taking way too much fascia, having a huge margin, and now my friends are stuck trying to figure out what we're going to do with this giant hole in the wall. So when you do, reconstruction, you all are experts. I'm not going to lecture you on it, but let's say in general, most of these patients are going to require some component separation. Obviously, they're going to have mesh in most situations. The guy tomorrow, or next week, we're going to put a temporary biologic mesh for bridging if we need to, and then kind of deal with the consequences later when we don't have a huge infected/tumor field. All right. The recovery, as you know, can take a long time with these, and a lot of these patients will develop what I call gastric ileus or kind of gastroparesis. It's going to take a while for them to get their nutrition up, and we just have to support them through it. But they generally do pretty well, and their symptoms definitely improve, and they're thankful for it. All right. And then recurrence is very, very common. You're not going to be able to avoid that. Some people will have recurrence elsewhere in the body, but it is relatively common to see recurrence in the peritoneum. The recurrence in this actual local area is actually relatively low, which is good. But I think getting the tumor out spares them a lot of morbidity down the road, even if their overall disease biology is not favorable. It does give them a good quality of life, and I think it's worth doing. All right, thank you all, and appreciate any questions.
All right, thanks everyone for those wonderful presentations. We only have about 3 minutes of time for some questions. Any questions from the audience? I have a question for Dr. Ledet. It seems like the concept of the mesh footprint is quite a significant kind of impact, especially in your population. Is there a specific mesh that you'd like to use for your patients?
So I use the typical meshes So typically I use barred soft mesh as normal prosthetic meshes, but I also have in my armamentarium, I use Phasix for some patients. I use Ovatex for some patients. I use Ventralite and separate mesh, composite meshes. But normally for most of my cases, I'm able to just use a barred polypropylene soft mesh.
Do you think that the age makes a difference in your decision at all?
The age typically doesn't. What makes me decide differently is, of course, the type of repair, but really If a patient is going to have reoperative surgery, the level of contamination, it's kind of the same as it would be for the general population.
Thank you.
Dr. Tovar?
And for Doctors Lede and Amal, is either primary cancer or metastatic cancer more or not likely to seed onto mesh?
Oh, thanks. I think, so that's a good question. It's, we don't have a ton of data. I would say that, you know, in patients who have had prior mesh and now they have peritoneal disease, I haven't seen that the mesh itself seems to have more mets on it than, say, the rest of the peritoneum. Primary tumors, there depends on the histology, but especially mucinous tumors tend to seed port side, seed the incision. And so you can see it go onto the mesh, but I don't think it's necessarily a higher likelihood than the rest of the abdominal wall.
I would agree with that statement.
I do have something to add. The only time I've had an oncologist say, I do not want you to do an abdominal repair is in desmoid. So desmoid needs to be reactivated by surgery. And so that's the time where I've almost had them say, no, please don't operate on my patient. Every other time they're like, please, please, please fix my patient.
I have a quick question too, since we were talking about so many immunocompromised patients. One element of this kind of rehabilitation that we didn't focus on is, frailty and physical readiness, which I think is particularly relevant in you guys' patient population. Could you just talk on what assessment that you guys have of that, and if you work with physical therapy or any other departments?
So surprisingly, they come to our clinic relatively well, because we see these patients in survivorship or in surveillance. So a lot of times they have finished their primary therapy. They are actually on the mend. They are hiking mountains, fishing, riding bulls, lifting deer stands. I'm in Texas, so that's what they do. But they are literally very active. And I'm shocked because that was my preconceived notion that they would not be habilitated enough to do that. Now, are there patients that do that? For sure. So we do things that are related to prehabilitation. We make sure that they can walk, that they have physical therapy. I would say they're kind of in the lower end. They're not quite the majority. We see more older patients, and I think that's where it gets a little tricky. So back in the day, we didn't operate on people who are 70. Now that's the average age in our clinic. And so geriatrics is actually a more important consideration in this population than not. And it's becoming more and more important as our baby boomers become older.
I think that, during the kind of the pre-survivorship period, I think that's also what we see is that I tell the patients, you're going to be in this down the road in the same condition you are coming in. So you want to be in as best shape as you can. And the chemotherapy has really changed. There's obviously, if you're looking at, we're all talking about solid organ disease, and the chemotherapy agents, the side effect management is much, much better than it was historically. And so I think a lot of these patients kind of hit the ground running compared to where they were just 10 years ago.
All right, I think that wraps up this session.
Thanks.
Thanks, everyone.